I can talk really fast. And so here is the deal. I'm talking about a very big topic, um, and in not a ton of time. But the good part is that a lot of what I'm sharing is like very focused on making sure you have a resource to refer back to. I'm happy to share a PDF of my slides so that people can have those resources. And also, I'm a big fan of QR codes, and so there'll be a lot of QR codes popping up on the slides that you'll be able to use that to access some of the things I'm going to be talking about. So I'm going to hit the highlights today of the perinatal mood and anxiety disorders. And so I'll be briefly talking about epidemiology, risk factors, largely just with the idea of like using risk factors to identify patients. I'll present the diagnostic criteria and some symptoms with really mostly an emphasis on some unique things we see in the perinatal world. Um, I'll talk about screening tools and resources for screening supports if those are things that you need, and also some referral and education sources. And then I'll also talk about, a little bit about what I'm not going to talk about today at some point. One, I love PSI. And so this provides a nice overview of the perinatal mood and anxiety disorders. Um, the I don't know if you can see me and my screen, but it looks a little different now. And so you can get this off of the PSI website. And actually, you can even individualize it for your organization. So I had some made with our Meadowlark logo. Um, but really, it's just a lovely thing because it makes note of all of the different spectrum, some just a small subset of the symptoms people might see, risk factors, treatment options. And so I think this is a really lovely graphic that can be used clinically. So before talking about disorders, I'm going to talk about something that's normal, right? Anything that hits 70 to 80% of women, we can't call that a disorder, even though it doesn't feel good. So the blues, and I don't know if anybody remembers the Baby Blues comic strip, but I certainly do because I was just right that age. But that follows, these parents all through the spectrum, and the challenges start early, right afterwards. Although certainly pregnancy can be a challenging time as well. And we think of that hormonal component, the baby blues. The symptoms have epidemiologically been shown to peak around the fifth day, which is interesting when we think about some things we see in some of the cases. It is associated with premenstrual dysphoric disorder history, a history of depression. And I'll talk about that in a minute. But like the symptoms, things like crying when it doesn't make sense. I certainly remember doing that myself. Trouble sleeping, confusion, sadness, mood swings, irritability, not feeling like yourself. Those are things that can look a lot like depression, but we don't want to mistake it for depression. And I'm not going to talk about treatment, but since the blues is not something that we really treat, what I want to emphasize is that women have a lot of needs that will help them get through the blues. And something that I really want to emphasize is that you really do need to monitor when you see the blues, because postpartum depression is at least four times more likely, if not more, in women who get the blues, indicating the hormonally sensitive component, but also shared risk factors. So, what I'm going to try to cover very briefly in my time that's dwindling, major depressive disorder, that can be called a lot of different things in terms of depressive symptoms and what we officially diagnose it as. And it has some treatment implications. I'm going to talk about bipolar disorder and postpartum psychosis. I'll talk about some of the anxiety disorders, or at least give you some resources for thinking about those, including the very common ones of generalized anxiety disorder and post-traumatic stress disorder. So, what this means I'm not covering is some of the other anxiety disorders like panic, social anxiety, phobias. I'm not covering other bipolar disorders. I'm not covering substance use disorders. That will be covered in October. I'm not going to be covering other psychotic disorders like schizophrenia, although we'll see that one of the case discussions We will kind of talk about it in that context, and what I'm presenting will be useful as we think about that. And then I'm also not going to be talking about treatment, and I'm also not going to be talking about non-treatment and what the risks are of that. My colleague, Dr. Lundquist, will cover that in July. So you can see that, like, the number for what we say about perinatal depression or perinatal mood and anxiety disorders, it can vary widely based on the source. The one that I see, I think probably most commonly these days, is the 1 in 5. And that's the PSI graphic has changed for the 1 in 5. And this, based on like my, the long time I've spent in the field, this seems like a really appropriate number in general. Although your patient populations, or the maternal child health center populations, when we've looked at data from those, it's much higher. So 1 in 3 may be what you're looking at in your settings, and I would say that's not surprising either. In a really nice large research study not terribly long ago, a little over 22% or a little over 20% had depression in the first year postpartum, and we're just looking at depression then. So if we think about all the anxiety disorders, that's much higher. We can see a lot of the depression has a comorbid anxiety disorder, and a good chunk of that depression is actually a bipolar illness. The anxiety disorders. Also very common, 20% overall, and a combo of the kind of hitting the highlights of the ones that I'm going to emphasize as most common. Postpartum psychosis, thankfully quite rare, and this number really does seem to be pretty consistent when we talk about the epidemiology. Largely, we think about it as a 1 in 1,000. But when we see it, it's really important to get that taken care of. Most of that is actually a first-time episode of a bipolar illness, and the majority of women with postpartum psychosis will meet the criteria for bipolar. So this is a slide with a lot of information on it, and really what I want to just hit the highlights of is being able to like look back and think about what are risk factors, that I'm seeing in women, because those risk factors will help us to identify who might be more likely to go on to have an issue. And so certainly like the biggest ones are a past history of postpartum depression or a past history of postpartum psychosis for those respective disorders, a family history, especially for postpartum psychosis. There was just recently another article really reinforcing how important that is as a risk factor. But you can see there's a whole range of the biology, like giving birth, and the like other stresses, which are generally more significant than changing diapers. But women who stop their medicines, the hormonal component, which may be linked to the genetics, perinatal complications, not sleeping, individual traits, social support we know is huge, and then stressful life situations, and that can have, really run the gamut. So you've probably seen this list before, and these are the symptoms of depression. And I think the important things to see about this are the top 2 criteria: depressed mood, or you could interchange irritable mood. Most of the day, nearly every day. And then this decreased interest, that anhedonia criteria. There are top 2 and important questions to focus on. And then the other thing that I emphasize from this is like there are all these other things, though, that really overlap with the experience of being pregnant or postpartum. So changes in weight, changes in sleep, changes in energy. What's not common between the 2 of them is thoughts of death and suicide. When we see perinatal or maternal postpartum depression, it can look a little different in certain ways or have this particular qualities. And so I want you to have some sense of what some of those might look like. It's very common in particular to have obsessive thoughts or anxious thoughts that don't necessarily mean a separate anxiety disorder. In particular, we see the ones about baby safety, baby's health, is my baby breathing? And that can result in a lot of hypervigilance hypervigilance and decrease in sleep. Thoughts about harming the baby are actually really common as a part of perinatal depression. And these are thoughts that are generally considered intrusive, unwelcome to the woman, and something that she's not at risk for acting on unless the situation is more than perinatal depression. But these are some common things. We also see women who aren't connecting to their baby or really want to escape. And a really common word that women use to describe how they feel is simply overwhelmed. Bipolar, basically the important things, depressive episodes and these manic episodes, that I won't talk too much about what they look like, because I'm going to talk about what postpartum psychosis can look like. And that's most often what we might see when somebody is presenting with a postpartum bipolar episode. In general, we consider it bipolar unless proven otherwise. There are some women who only have postpartum psychotic episodes and don't meet criteria for bipolar, but that's the minority. Postpartum psychosis can look like complete confusion. It can look like delirium. They should be evaluated for delirium for sure. And it can cause a lot of memory difficulty, mood lability, as well as things that we consider classically psychotic, like hallucinations and delusions. Those delusions will often involve the infant thinking their baby has been replaced, or that the only way to save their baby is to end their baby's life, things like that. And so there is a small but significant risk of infanticide with postpartum psychosis, as opposed to those common unwelcome thoughts of harming the baby that could occur with depression. It is considered a psychiatric emergency. And something that I just want to highlight, and I borrowed this slide from MCPAP for Moms, who I'm going to mention as a resource. Basically, anxiety disorders, including OCD and postpartum psychosis, can actually look a little bit alike at times with the intrusive thoughts and worries. And so I just want you to have like a sense of a resource that like could help you distinguish those from one another. So OCD, and I know my time is short, but I just want to hit the highlights here. Intrusive, unwelcome thoughts that are distressing. We call that ego dystonic. They're often baby focused. And women can have obsessive compulsive symptoms without having an OCD diagnosis. It's very time consuming, causes a lot of distress, can impact the whole family. And I would say that during the pandemic, I saw a definite uptick in OCD, especially contamination fears, hand washing, in addition to the thing that I always saw for years and years, which was obsessive checking of the baby's breathing at night. Generalized anxiety disorder, the worry tends to be more general and less obsessive, but more ruminative. Women feel trouble, restless and keyed up, have trouble concentrating, a lot of physical symptoms. And so oftentimes women will actually present more with the physical symptoms and have a sleep disturbance of not being able to sleep when the baby is sleeping. PTSD requires the trauma exposure. Perinatal traumas are included in that. We have these categories of symptoms: re-experiencing, avoidance, the hyperarousal symptoms. And I just want to point out that there's some particular things that we see when we see perinatal PTSD. So this detachment, avoiding contact with care providers, fear for children's safety, fear of breastfeeding, fear of delivery or fear of delivery in the future. And that can have a whole host of consequences for the woman and for future pregnancies. We know that detection is hopefully getting better, and it seems like Iowa is doing, a lot of work around that, and has been for over 20 years because I've been involved all along. But it remains pretty low. Some populations are particularly vulnerable to not getting screened for a variety of reasons. We know if it's not detected, that means it's going to be undertreated, and really only about 75% of women are going untreated still. Professional organizations, as you know, recommend screening, and yet rates remain low, or if they're screening, they're still not using validated screens. So we know there's a lot of system barriers that remain, even though there's been certainly changes in the last 20 years that I've seen. Women experience a lot of barriers, and we'll talk about some of these in the cases. Cost, time, previous negative experiences, concerns about taking a medicine in the perinatal period, and then providers have their own set of barriers, as I'm sure you've experienced. There's a lot of challenges in identifying. And so, like we talked about, the normal pregnancy postpartum can have those changes in appetite, changes in weight, changes in sleep, changes in energy, changes in libido. And so, this is why we screen with things like the EPDS, which was designed to identify or to address those issues. So, screening, we know it increases detection, reduces the prevalence of depression as a form of prevention. It can improve treatment rates and remission, and shorten the duration. And as we already talked about, screening is recommended by a lot of US organizations involved in this. Canada has some reasons that I'm not going to go into for not doing that. But basically, the idea is we need to be screening, especially in at-risk populations, and then we need to have resources to address it on the other end. So if you're not already screening or you need additional resources, these are some of the top ones. The MCPAP for Moms has some really awesome toolkits, some algorithms, and also talks that you can borrow. So I had a slide earlier, the one about OCD that I got from a MCPAP for Mom uh, uh, PowerPoint that you can download. And other things to know about some of these. I'll talk again about PMH Connect in a little bit. So I just wanted you to have these resources. And the MCPAP for Mom has an associate perinatal access program. That's essentially what it is. And so that's certainly something we hope to develop in Iowa. So that may be of interest. And then I just love PSI. They've got great resources. And so I'll come back to that briefly. You know that we should screen all women because you can't tell by looking, which this cartoon really it addresses. What should we use? Really, you use what works for you, what you're already using, as long as it's validated. The EPDS, this QR code takes you to the non-English versions because there's a lot of them, which is exciting. The EPDS you can use in so many different populations. You can use it in partners, you can use it in adoptive parents, and it also will pick up some anxiety if you're using only one thing. And there's the EPDS, which you may be familiar with. And then if you haven't heard this news, I think it's super, super exciting. The EPDS US is available for use. It's been through a smaller study and is now in the process of a larger validation study. So here's a link. That's that PMH Connect website. Some researchers worked very hard to get one that seemed to be more understandable to women in the US, because if you've used the EPDS, you know that the language is sometimes a little bit not how we talk around here, right? So this is super exciting. And they do have some other aids with it that I'll show in a little bit. In terms of what else we can use to screen, the PHQ-9, the PHQ-2, the PDSS, but that costs money. Who wants to do that? Who else should be asked? This is my plug for dads. It's been a pet topic for me for almost 20 years. And so I just want you to know you can use the EPDS with fathers. And I think that fathers are relevant in one of the cases we're going to talk about. And there may be a variety of ways we have to be creative in how we reach dads. Other screens, and I'm going to click through, but basically the GAD7, if you're using that, a lot of people are. If they're using either the PHQ-9 or the EPDS, they may combine those. There is a nice PTSD screen available that you could use that's recommended by ACOG, for example. There is a bipolar screen, the MDQ, the mood disorder questionnaire. I apologize, this bipolar disorder screen that just is like some questions from MCPAP doesn't show up super well, but you can click to that link if you wanted to do something shorter than a formal screen. The MDQ, I'm just going to tell you, you will pick up a ton of anxiety. So it may look positive, but I will say that that does not necessarily mean the woman is bipolar. Um, and then we want you to be prepared for if somebody screens positive, be able to make effective referrals. And so here are some nice tips that when we share with the slides, you can um, check back on those, but I really want to emphasize talking to women about their barriers to treatment, their previous experiences, their preferences, having a good list of resources, having education available, and really making sure that you individualize things and follow up. And referrals are really important, especially if the things are severe, or if it's complex with a lot of diagnoses or comorbidities, and also if somebody's not responding to treatment in an early time frame. This is that PMH Connect resource. It can be a good referral tool. And then HRSA, PMH Connect, PSI, all have some really great resources, posters for your walls, all sorts of wonderful things. And we're going to talk about the cases, but also I can take questions. And had I not had such technical difficulties, I would have been done closer to on time. So I'm going to hit stop sharing.